Hello, welcome everybody. My name is Anissa Camadoli-Costa, and I serve as chairman and president of the Tiffany and Company Foundation, based up here in New York, and I'm also lucky enough to serve on the board of Philanthropy New York. And I wanted to welcome everyone here today on this rainy Monday afternoon. As one of the co-sponsors of today's panel, we were proud to co-sponsor this panel because I think that, especially sitting here in New York, Ebola is a crisis that is seen as something that maybe has passed or is under control to some extent, and yet it's very much still an issue. And it's also an issue that all of us, hopefully in this room, and definitely many of us who aren't in this room, it's something that impacts our lives, whether it's through our businesses, through our grantees, through the program areas that we fund, even if we're not directly involved in healthcare funding. I know that we at the Tiffany and Company Foundation do not fund healthcare per se. However, the Ebola crisis has been something that's impacted us in many different ways, and so it was important to us to bring, to help convene this group, this wonderful panel here together to talk about the issue today. So with that, I wanted to turn the floor over to Hope.
Thank you, Anissa, and thank you everyone who's here in the room, and those of you also who are online and didn't brave the rain like our colleagues that are around this table, but it's fantastic to have you with us in whatever form you are. I am very delighted to be here and talking about what, as Anissa had said, is an issue that I think many of us in the States, it's not as much on the forefront of our minds, unfortunately, and I think as our distinguished panel will discuss, it's still very much ongoing, very much real, and I appreciate their time and their efforts to join us today. This is a really interesting time to be having the discussion. We are about 10 months out from when the first case was diagnosed in March of 2014. It has turned into an epidemic that is larger in scale and in terms of deaths and number of people affected than the total number of cases from when it was first diagnosed in 1976, which gives you kind of a real feel for what has happened in 10 months. And unfortunately, the numbers that have often been cited are believed to be rather underreported, as I'm sure our panelists will discuss today. What we're going to do here, we are here to talk about kind of both the current situation as well as philanthropy's response to Ebola, both immediate needs and then longer term needs. And the topic, as it was written up, was called the multidimensional approach. And I think we were going to hear about multidimensional approaches on the ground as well as multidimensional approaches within philanthropy to respond. And we are fortunate to be joined here by 3 distinguished speakers, each who will give their own perspectives in terms of their work and the philanthropic response, giving us that multidimensional feel. So we have, and I'll kind of start from the end here. We have Andy Bryant, who's with the Last Mile Foundation. I just lost my train of Last Mile Health. Thank you. Okay. Thank you. Jeffrey Wright, who is an actor and activist, and who created the Ebola Survival Fund. And then lastly, we have Niamani and Mutima with the Africa Grantmakers Association. And what you will hear from them, they're each going to talk for about 10 minutes to present their work and their perspectives. And then I will kick it off with some questions to get a conversation started. And then after that, we'll invite all of you to ask some questions of our panelists. And ideally, we'll open this up to be a discussion to hear about both their work, your impressions, and what we can do next. So with that, let me turn it over to Jeffrey.
Oh boy, thank you. Oh. Thanks to all of you for being here on this sunny day. I thought, as I am an actor by day, that I would read from a prepared script that I put together here, just to give an overview of the approach that we're taking and who, what, and why. The first mistake I make will be the last mistake I make. We do it for our country, for our families, and for ourselves also. So confesses a member of a Sierra Leonean Ebola victim burial team in a UN video released in October 2014. We never learned the man's name. We know him by his selflessness, pragmatism, and courage. Here in the United States in October, New Yorker Dr. Craig Spencer's Ebola diagnosis was fodder for more paranoid national news headlines and fears of bowling in Brooklyn. Amid cries for involuntary quarantines of him and all other American healthcare workers returning from West Africa, travel bans, and cancellation of non-existent direct flights to the U.S. from Guinea, Liberia, and Sierra Leone, Ebola became an election issue. Representative Steve Stockman of Texas went so far as to wonder out loud if what he perceived to be a slow U.S. government response to Ebola wasn't, quote, intentional in order to create a greater crisis to use to take control of the economy and individuals and so forth. Like the baffled congressman, many Americans were spinning out in panic anticipation of an imminent Ebola-fueled apocalypse coming straight to our shores from the African heart of darkness. I was unconvinced. For over a decade, I've traveled regularly to Sierra Leone's eastern Kailahun district. In 2003, with 2 retired U.S. Army senior officers, I co-founded a gold exploration and mining company, Taya, toward building a natural resource-driven development model there in partnership with a community called Pinguia Chiefdom. Pinguia lies about 40 miles west across the Guinea-Sierra Leone border from Meliandu, the Guinean village where 1-year-old Emile Wamano, theoretical patient 0 in the Ebola outbreak, died in December 2013 behind the back of global concern. In May 2014, Kailahun became the first district in Sierra Leone to report Ebola fatalities. In 1991, Sierra Leone's rebel war ignited there as well. Inhabited by people who subsist primarily on agriculture and mining, it's as verdant, fertile, and beautiful a region as one could hope to visit. It's also isolated, often forgotten, and despite being blessed with significant natural resource potential and 12 years of peace since the war's end, vulnerable to a threat like Ebola virus disease because of its fragile health system. Pinguia reportedly lost a doctor to Ebola in June. He was infected, we were told, by a nurse visiting from outside the community. Beginning in July, Taya Peace Foundation, our 501c3 not-for-profit social development entity, diverted monies away from social investment in agriculture toward enabling infection prevention and control measures via chiefdom authorities, e.g. chlorine supplies and protective medical gloves for the 4 local health clinics, chlorine and other materials to establish 97 chiefdom-wide public wash stations, and bullhorns to spread Ebola awareness and information after public gatherings had been banned. Thai Peace Foundation responded to the outbreak early, urgently, and in direct, regular communication with community leaders and representatives. According to multiple local sources, since that unfortunate doctor, no one else there has died of Ebola. It's just 40 miles from patient 0. We continue now to support Pinguia's infection prevention and control measures, which now include chiefdom border control efforts, and we also fund seed for rice production to help address food security challenges and to uplift the local economy negatively impacted by the outbreak. And we're now undertaking similar efforts in Pinguia's western neighbor, Yahweh Chiefdom, where over 50 people have died of Ebola at last report, and 65 children have been orphaned. Months before the end of the year New York Times Ebola special, which focused largely on the missteps of the World Health Organization and the CDC in intervening early and consistently to contain the outbreak, an August 9th, 2014 New York Times article concluded that the spread of the disease out of the rural tri-national border region of Guinea, Liberia, and Sierra Leone is, quote, partly a consequence of modernization. But the minimal national government presence in the area, the deeply rutted laterite roads overgrown at their sides by dense grasses, the absence of widespread access to electricity, and under-resourced health facilities do not constitute modernity for rural West Africa or anywhere else. The virus spread with the help of 3 drivers. 1, the routine international movements of people living there who crisscrossed the borders largely to trade agricultural goods or precious minerals, or to make social visits such as attending funerals of relatives or loved ones. Members of the Kissi ethnic group live in all 3 countries in that area, the boundaries of their ancestral lands not conforming to colonial borders. 2, a lack of urgent national or, yes, international concern and action in response to the initial outbreak. And 3, perhaps most critical, but least examined by news reports, the absence of local modern development, including modern medicine. Partners in Health co-founder Dr. Paul Farmer wrote last September in his key principles of the Ebola response, Ebola has not yet come into contact with modern medicine in West Africa. But when protocols for the prevention of high-quality supportive care are followed, the case fatality rate may be lower than 20%. Case fatality rates in parts of West Africa have been as high as 80%. In 2012, Taya Peace Foundation engaged International Surgical Health Initiative, another US-based 501c3, to perform a medical and surgical needs assessment of Kailaun District's private Nixon Memorial Methodist Hospital, the nearest large facility serving Pinguia and its neighboring communities. Among the other serious deficiencies, ISHI reported the hospital was short of basic supplies utilized for daily patient care, including gauze and tape for wound dressings, catheters for administration of IV fluids and medications, anti-malarial medications, and suture material. Hospital staff described the availability of only 7 cloth gowns to be sterilized and reused for all aseptic purposes. In addition, ISHI reps noted that the Nixon Memorial's operating room was lighted intermittently, but by car battery. The hospital is one of 2 serving Kailaun's 400,000 residents. I'm not an infectious disease specialist, but I can differentiate between a modern hospital and none at all. There's not a hospital anywhere in the United States as ill-equipped as those I know of in Sierra Leone. I've personally visited several hospitals and clinics there. Yet many Americans responded to the first U.S. Ebola cases as though our healthcare capabilities were equivalent to those in parts of West Africa. But after being easily managed in the United States by our healthcare system, Ebola fell from the radar of American public interest. Sadly, Guinea, Liberia, and Sierra Leone particularly still fight to contain it. Critical to those countries fortifying against Ebola and any other future health crisis is vitalization, not revitalization, vitalization of healthcare delivery systems and infrastructure, which prior to the outbreak were already weakened by underinvestment and the distress of recent unrest. But why would local healthcare systems be so weak prior to the outbreak when these countries received significant foreign aid? Indeed, Liberia, for example, received approximately $571 million of foreign aid in 2012, but only 3% of that went to national institutions, with the lion's share going to foreign NGOs and international organizations. Imagine you're the Minister of Health in Sierra Leone, Liberia, or Guinea, and the vast majority of your country's aid is bypassing your institutions. Your national plan is 90% unfunded, but the leading healthcare NGO in your country has a fully funded budget, triple the size of yours. Imagine that you are responsible for the well-being of your people, and when a health crisis like Ebola hits, it's the foreign agencies and NGOs which organize and implement your country's response. Imagine as well the temptation toward corruption when your ministry, like others in your country, is so woefully underfinanced. In the West, we often wag the finger of judgment at corrupt governments as the chief encumbrance to progress towards self-reliance in jurisdictions like Guinea, Liberia, and Sierra Leone. Corruption is indeed a serious problem in these countries, but rarely do Western critics target the corrupting influence of the Western development community, let alone the private sector, which too often works harder to maintain its own relevance and heroic image than to render itself obsolete. Kailaun District is littered with signs advertising the good works of one foreign group or another. The signs are often more evident than the evidence of the work advertised. Taya Peace Foundation, our group, is guilty of this. A sign at the head of an 18-mile feeder road we rehabilitated in 2011 in collaboration with the Sierra Leone National Road Authority is now in better condition than the road itself. Taya Peace Foundation raised the monies to rebuild the road, but neither TPF, the Sierra Leone Road Authority, or chiefdom leadership could manage funding to maintain it. Hard seasonal rains and new heavy traffic pounded its once smooth laterite surface, and now the ambulances that had enjoyed new access to the previously inaccessible again struggled to make their way into an area that, in addition to lying at the heart of the Ebola hot zone, suffers from some of the highest maternal and infant mortality rates in the world. Local women experiencing complicated labor most often enjoy no available emergency medical care beyond what their local midwife and their own strength and good fortune can muster. Will the work underway now to contain Ebola in West Africa resemble that road in a few years? What will be the legacy in Guinea, Liberia, and Sierra Leone once the disease has been contained and the foreign NGOs and agencies which help that containment have moved on to the next global health crisis? Will they tend to the regional health crisis looming in 2015 because of Ebola exerted pressure on food security and the potential for resulting malnutrition to weaken effective treatment when available of other common illnesses? Will they address increased maternal and infant mortality rates? Will they treat HIV and AIDS? Will those same first responders have to circle back to the region again in 10 years' time for the next crisis? Many of them were there 10 years ago to help rein in the violence and negative impact of war. Not one new hospital was built in the region during that time. Ominously, at a December 5 UN ECOSAS meeting, Sierra Leone Minister of Finance Kafala Mara explained that to that point, $712 million in Ebola response aid had been deployed to his country, but only 5% was channeled to national systems. Still, more than an opportunity for criticism of transgressions, the West African Ebola crisis offers the development community a chance for course correction away from business as usual and toward a paradigm shift. Under the Ebola Survival Fund, we've organized a coalition of development groups, most of which were active in Liberia and Sierra Leone prior to the Ebola outbreak. The Ebola Survival Fund is focused on filling gaps in the immediate response needs with a vision towards strengthening and modernizing local healthcare systems and infrastructure and supporting local economic recovery. ESF partners Wellbody Alliance and Shine On Sierra Leone identified one such gap, home healthcare kits, which they are distributing to communities in Kono District, Sierra Leone, now experiencing alarming spikes in new Ebola cases. In Liberia, Nobel Peace Prize laureate Lema Bowie's Bowie Peace Foundation is leading Ebola outreach and awareness initiatives in partnership with 12 community-based organizations across that country. Partners in Health is the leading healthcare group within the coalition. PIH and Wellbody Alliance have established Ebola treatment units in Port Loko and Kono, Sierra Leone, respectively. Last Mile Health is doing similar work in Liberia, and their founder, Raj Punjabi, is technical advisor to the fund. UNICEF is an ESF collaborating partner, as is Mass Design Group, which for $5 million in 2010, $5 million in collaboration with the Clinton Foundation and Partners in Health, built and equipped a hospital in Butaro, Rwanda, inclusive of the first cancer ward in rural East Africa. When I had the privilege of visiting Butaro with President Clinton in 2012, my eyes were further widened to what is possible and necessary in Kailaun, modernity.
Jeffrey, I don't want to cut you off, but I am mindful of the time. This has been a fantastic kind of overview.
Great, I'm almost there.
Okay,
Thank you very
great.
much.
No,
Bringing it home.
No.
Bringing it home.
But I think this has been excellent for us to get a good lay of the land.
Great, thank you. The Ebola Survival Fund Coalition differs from other actors on the international development stage in the following ways. Ebola Survival Fund member groups are committed to working with national governments in alignment with national plans. 2, Thai Peace Foundation is the development arm of a company equally focused on local job creation and prosperity building through investment in mine development and mining, taboo within traditional development circles, but to the citizens of Kailaun, Sierra Leone, and many other parts of the Mano River region, rice and gravy. 3, Partners in Health is new to the region. They, Wellbody Alliance, and Last Mile Health in Liberia are committed to providing the highest level of treatment to West African Ebola patients, including IV fluid therapy, and neither group will consider their mission accomplished until strengthened national healthcare systems and infrastructure are in place. 4, Mass Design Group builds hospitals. They currently have shovel-ready plans for a pediatric facility in Monrovia, Liberia, for example, pending approximately $10 million of funding. Bowie Peace Foundation Africa is not a foreign entity in Liberia, and their mandate is to bolster the capacity of grassroots community-based organizations. Another Ebola Survival Fund collaborating partner is the US-based organization AIDS Health Foundation. AHF sponsored the work of Dr. Umar Khan, Sierra Leone's leading HIV, AIDS, and Ebola specialist. Dr. Khan died of Ebola in July 2014 after neither receiving any experimental medicine nor being evacuated to a Western hospital like American healthcare workers afflicted at that same time. Ebola Survival Fund would love nothing more to build a hospital in Sierra Leone to the memory of Dr. Khan. Last week, Ebola Survival Fund released a PSA featuring 2 Sierra Leonean Ebola survivors, Hasfata Toure and Mohammed Now. Paul Farmer, Jennifer Lawrence, and other of my Hunger Games colleagues were there as well. The framework of the message is straightforward and inspired by allegory offered in the Hunger Games stories. We in the affluent U.S. are more like Pan Am's capital than we may care to admit. Guinea, Liberia, and Sierra Leone are like the Hunger Games District 12, the neglected mining district. In the PSA, Josh Hutcherson asked Jennifer what would happen to her if she contracted Ebola. She answers simply, "I'd be fine." And according to the statistics, she's correct. Every American afflicted with the Ebola and treated in a U.S. hospital has survived the disease. In West Africa, graves for Ebola victims are still dug every day. Americans reacted to Ebola out of misplaced self-concern and an underappreciation for our own country's privileged position relative to many within the global community. And forever.
Thank you, Jeffrey. That was a terrific overview as well as, pardon?
Can I go beyond 10 minutes?
Just a little bit, that's okay.
Forgive me.
It's a good framing, and I think it leads perfect into Andy talking about his work with Last Mile Health, as well as I should mention that Andy also wears two hats, which is quite germane to us around this table. He also serves as the executive director of the Segal Family Foundation. So with that, I turn that over to you.
Yeah, thanks, Hope. Thanks, Aditi and Anissa and the Philanthropy New York folks for having us. It's an important conversation. Excited to get to the Q&A part too. Yeah, so my day job is as executive director of Segal Family Foundation based in New Jersey. Mission is to improve the well-being of communities in sub-Saharan Africa, which is quite broad. In practice, this has meant deploying about $12 million this year in grant capital to about 200 NGOs across about 20 countries in the continent. Most of these are indigenously led organizations. Our focus is on secondary, tertiary education and reproductive health. Through Segal Family Foundation, I came to know Last Mile Health. Been a long-standing partner, and it's been our privilege and honor to support them financially and in kind. And ended up joining the board of directors a year and a half ago or so. And it's been quite an interesting time to be on a board of directors. So that's my big mea culpa is I am, in fact, a board of director. This is supposed to be Leisha McCormick's seat here, who is the development director. So I just beg that any sort of particularly detailed questions you have, I'm going to beg him off. So Last Mile Health is committed to saving lives in the world's most remote villages, hence the name. Doing this by building a health system that reaches these villages by training, equipping, and supervising community members themselves to be health workers for their villages and connecting them with rural health facilities. It's because Last Mile Health was founded by Liberians and has served Liberian communities for years. It has a heck of a lot of technical expertise. It's really well suited to be part of the Ebola response. Okay, so Last Mile Health's experience with Ebola. Last Mile, as mentioned, Last Mile trains and equips villagers themselves to be healthcare providers in very remote parts of Liberia. So in practice, this means immunizing children, getting mothers to deliver facility-based deliveries, identifying and treating malaria, waterborne disease, and pneumonia, sort of like the top 10 killers of women and children. Things that can be simply combated if either prevented or identified and treated at the onset of the disease. And of course, referring more difficult illnesses to facilities that they're helping to improve best practice there and some of the facilities and infrastructure. Sort of prior to Ebola, when Liberia was not as sexy of a destination for donor dollars, the health situation was pretty dire. A couple of facts. In the wake of the Civil War from the 1990s, early odds, 51 doctors left for a population of 4 million people. 34%, about a third of the country, has access to, not a little bit, but no Western medicine, no healthcare, either through health outreach or through facility-based services. And just to backtrack a little, Last Mile, when we describe the work they're doing with this third of the population that doesn't heretofore have any access to healthcare, really means Last Mile. I wish Dr. Raj Punjabi, the founder, a Liberian, was here to explain this, but the imagery he uses is really evocative. On my site visit there, we drove 15 hours out of Monrovia. We slept overnight. Next day we got up, we drove 3 more hours, got on the backs of the motorbikes, drove 2 more hours, got into a canoe, crossed the river, hiked a couple hours, and we reached the least remote village they serve. So truly last mile. Over the past few years, last mile's gone from sort of idea to pilot to proof of concept, and it's sort of now ready to scale its model of community health worker training, equipment, and supervision. And this has been part and parcel with partnership throughout with the Ministry of Health in Liberia. They've got a great working relationship with a lot of great folks at the Ministry of Health, really under capacity. They're working at the national level in Monrovia with the minister and deputy ministers on policy and development of curriculum for national training standards for community health workers and the like, as well as with county health teams, sort of at the local level, trying to forge relationships and provide some best practice training and inputs for people working on the ground in these remote places. Both Last Mile and the Ministry of Health believe that the cultivation of strong community health workers doing this outreach is really the center of an effective strategy to restore basic health services across the country. Ebola, like needless to say, altered the plans a little bit. So Ebola in Liberia, it's crazy to think it's been 10 months and that's all. It seemed like a lifetime. The folks at Last Mile have been working 25 hours a day for about the last 9.99 months. So what happened when Ebola got to Liberia? Given the weak system of healthcare, when Ebola arrived, suffice to say that most everything went wrong. There weren't enough beds, there weren't enough trained health workers, there was massive hysteria, not only amongst the general public, but also amongst health workers themselves about how Ebola worked. You ended up having to quarantine entire towns, as West Point in Monrovia was on. You had national NGOs tripping over each other. You had international NGOs parachuting in without much idea of what they were going to do when they got there. And you had funders doing what we do best, creating harmful earmarks, forging ill-suited partnerships amongst grantees, and advising on the crisis from a comfortable and ignorant distance. I'm a funder, so I can say that. The numbers dictate, it's really, really scary in and around Monrovia, and to a degree that's, fortunately, that trend is downward, while in rural areas where there's been far fewer cases, that trend is unfortunately upward. Fairly recent figures, I think, a Ministry of Health sit rep from late November put the numbers at 7,100 cases, 3,000 fatalities. I agree with maybe Hope's comment that these are, who knows, those are Ebola numbers. When you count the tens of thousands of folks who unfortunately have gotten either more ill or perished because a lot of clinics, primary care facilities, and prevention work doesn't exist anymore. So people are dying of X, right? So Last Mile Health's response. I want to turn the corner into what Dr. Punjabi would want to hammer away, which is the hope behind all of this. Last Mile Health has integrated Ebola response into its regular operating model. Specifically, it's trained its own community health workers and others to do case finding, contact tracing, and patient referral. It's almost like a plug-and-play module. You've got a pneumonia unit, now you're swapping in an Ebola unit. So it fits nicely, dovetails well with their existing model. To date, Last Mile is trained and equipped several hundred community health workers, including its own. It's also trained and equipped staff at 35 primary care facilities to provide inputs and training for them on the Ebola response. So what does that mean? There's been few cases in these remote areas where they work, but reliable data is frankly really, really hard to come by. I think the clearest impact of Last Mile Health's work to date is that most of these facilities that are working in their catchment area stay open and operational, so that if it is pneumonia, if it is waterborne disease, it's not a death sentence. The other major component of Last Mile Health's response is to second about 5 staff to the central ministry in Monrovia to help coordinate all the funding coming in from all of us, which is wonderful because it's chaos, frankly. This has been huge leverage for a fairly small organization and hints at the long-term potential to help craft the future healthcare landscape that Last Mile can help have in conjunction with the Ministry of Health. The way forward, this is a really exciting step, I think. Last Mile Health will continue to provide direct services on the ground and do some scale of its own direct service provision. And it will also seek to leverage partnership with the government to scale the model indirectly. On the ground, we'll be training and equipping community health workers to combat Ebola over the next 6 months and should reach about 400 community health workers trained by about June of 2015. It'll also, last mile will also continue to refine and expand its more comprehensive community health worker model to reach more last mile villages across all diseases, not just Ebola. Nationwide, sort of that leverage piece, huge opportunity to work with the Liberian government to adopt and scale the last mile health model nationwide as part of a reformation of the entire health system. Still early days, but there's a pretty good opportunity for last mile to work with the Ministry of Health and the Clinton Health Access Initiative on what would be basically a 10-year overhaul of the health system, the public health system in Liberia. Last mile would basically bite off a chunk as doing all of the outreach in last mile communities, about a third of the country's population, 1.5 million. Ideally reaching 11,000, a cadre of 11,000 community health workers who are able to sort of utilize last mile's model of training, equipment, supervision, and compensation. Theoretically, with the whole goal of mitigating future outbreaks, as well as providing stable long-term primary care to folks in these rural places. So you asked me to talk about challenges and solutions with funding. In the past year, not exactly a challenge, our budget's tripled. We had a projected budget for FY15 of 2.5 million. We're north of 7.
Can I ask how much of that is looking longer term, or is it just somewhat? In this current year?
Everything. So rough thing, which I'll direct this question to Alicia, but I would say more than half actually it's either unrestricted or has application for looking beyond the Ebola crisis. So basically beyond June 2015.
Excellent.
That's pretty cool.
That's great.
So yes, how do we do this? Tripling the budget. Thanks to fast, flexible support provided by funders like Tiffany, whether you know it or not, and Open Society, who I think is also here today. Okay, well, thank you very much. And also, by and large, funders have been willing to provide unrestricted funding and fairly quickly. So I think it's been kudos to the funding community for how fast and flexible they've been with their funding to Last Mile and other actors. Thanks also to a coalition that Jeffrey mentioned between Partners in Health, sort of the infrastructure folks coming in, building Ebola treatment units, along with 2 sort of on-the-ground outreach operators, Well Body Alliance in Sierra Leone and Last Mile Health in Liberia. So both local organizations with the trust and reciprocity of the communities in which they serve, they can combine with sort of technical expertise at PIH as well as their Haiti disaster expertise and learning from some mistakes and some successes to apply in this context. In terms of challenges, that coalition work has been really tricky. No doubt, when you're trying to when you're herding cats, it's really tricky. And so you have Paul Farmer and Dr. Pajabi on the ground in the middle of Liberia making promises and coming up with these grand visions, as visionaries do. Then the dev teams and the staff have to come along and make that a reality. It's been interesting. Another challenge, it hasn't been raising money during the epidemic, as you've seen, but rather the ability to absorb it responsibly. Lots of requests from folks like us to pull off mission, either geographically or in service provision. Huge challenge, and it's really hard to say no when up to this point in time, it's a scrappy startup that has to cherish every dollar it makes. So it's been really tough decisions, but I can credit the staff of being incredibly responsible in saying no. Maybe one of the biggest lessons from this is just that ability. Another big challenge has been building a sensible combination of long-term hires, so building for stable long-term growth versus short-term consultants that we can shed off our cash flow eventually. Still a work in progress. Last thing, with that aforementioned Clinton Health Access Initiative MOH partnership, it's by no means locked, but I do think it would be critical for sort of the long-term stability of healthcare in Liberia. Long-term planning and resources required to defeat future Ebola outbreaks and other more chronic failures of the health system. I think that would address it really well. I think all the parties, fortunately, are not cynical actors, but folks who are well-versed and well-placed to do that. So I think that the future, I hope that there's a lot of hope here. There certainly is on the part of our team, despite the stress and trauma that they've undergone there on the ground. I think things are I hope, headed in the right direction. Thank you.
Excellent, great, thank you. And that's hearing about your experience as a grantee and dealing with funders, and I have to say those 3 points that you had made in terms of the mistakes as best decisions we make as grant makers sticks with me. And it'll be interesting to hear Niamani speak about her experience working with a number of different funders and their responses, and ideally being better than that. So.
Thank you. It's interesting because I feel like we've sort of looked at the micro. So my comments are really going to talk more about the macro, which is to sort of step back a little bit and talk about how philanthropy has engaged with Africa in general, and then some of the work that we've been doing to try to draw attention to the Ebola crisis, but also to use that as a platform to talk about some of the responsive philanthropy practices that are important regardless of what the current situation is we're trying to address. So I'm not going to talk a whole lot about what the Africa Grantmakers Affinity Group does, but just to kind of give you a context as to why we exist and what it is that we're trying to do. We're a network of funders who care about Africa, AGAG, or emerged from the philanthropic support for the anti-apartheid movement during the 1980s and 1990s, and really emerged to support, to also mitigate the impact of apartheid on Southern Africa. So in 2000, it reconstituted as the Africa Grantmakers Affinity Group, which is kind of, we're kind of an outlier because we're actually, I think, one of the only geographically focused affinity groups. And so what's also a little bit strange about that is because most funders, and since most of you guys are funders, you know this, most funders don't fund in a geographic area. You fund a particular issue or a particular topic that they're trying to address. So what we try to do is to talk about funding in Africa in terms of a context. And so our mission is to promote effective, robust, and responsive philanthropy benefiting African communities. And our membership really reflects the diversity of the private philanthropic sector who have a formal mechanism for giving. And that's important because my comments are going to talk about that sector, because you also got faith-based organizations who are involved in funding. You've got individuals. Giving USA tells us that foundations really represent only about 14% of the overall giving of philanthropy by the US. So within that, formalized giving is a small part of that. And the membership includes funders of various sizes in terms of their endowment. So you have large funders, I guess one can call Gates, Ford Foundation, Rockefeller Foundation, who have large endowments, small endowments, middle-sized endowments, and various amounts of money that they devote to grant making in Africa. So within the sort of pond of funders who fund in Africa, you may have a foundation that's very large, that has very large endowment, but has a very small grant making budget that they devote to funding issues and topics in Africa. You also have a lot of different approaches. You have funders who support global initiatives, who support international organizations, who support intermediate organizations who are based inside and outside of Africa to carry out their programs. And also, funding that's re-granted to local organizations based in country. And they also support a variety of different types of organizations: academic, medical, research, policy institutions, advocacy organizations, service delivery organizations. And they also work at a lot of different scales, which is having global impact, for example, HIV, AIDS, malaria, things that have a sort of global implication. They also work on issues that are specific in some ways or perhaps impact countries in Africa more so than in other areas of the world. They also work in areas and focus on national organizations who are working to make an impact and bring about social justice and social equity on a national level within their particular country. Regional organizations, West Africa, Southern Africa, and also community-based organizations. And the issues range from public goods such as education, health, water, transportation, to human rights, democracy, economic growth, technology, capitalism. The reason why I wanted to sort of paint that is because that's when we talk about multidimensional, that's really what you're talking about. You're talking about an ecosystem in terms of philanthropy that enters at all of those different points. And we believe that a large and strong network of increasingly informed, knowledgeable, and connected funders who understand what some of the critical trends are and some of the strategies and some of the points of leverage, that this is what you need for good, effective, and trusted partners to work in terms of confronting issues such as Ebola. Now, although we use this term responsive philanthropy, which is used a lot, but we use it very intentionally because we want to communicate that philanthropy is a verb, okay? And it's a verb because effective philanthropy is done in partnership, and that African communities and African organizations are on the front line of social change. And contrary to popular belief, no intervention from the outside is ever going to cure any particular social issue, because you're dealing in countries and communities who have agency and who have sovereignty and who have infrastructures that are going to have to create the ingredients to address this. And so we feel that African communities are the architects, and that effectively addressing issues that concern and affect African communities, you have to respect their role and authority over their communities, which both of the speakers have spoken to in that regard. So we started to talk about how funders can make a difference, because one of the things, given that very diverse ecosystem of philanthropy, is that you had funders who can fund and want to fund on a large scale and large institutions like the CDC Foundation or Doctors Without Borders. But as many of you know, given the focus of your own work, some funders also want to have more of an immediate impact and want to be able to know that their funding is making a difference. So one of the things that we've tried to do is to highlight the different levels of engagement and to highlight the different types of organizations that are working at different levels, and to underscore that if you want to make a difference, you can make a difference. And that if you feel that you only have $5,000 to fund, that there are organizations, there are grant-making public charities, there are initiatives that you can support that can make a difference. So we, in some ways, are trying to remove the barriers to say, of inaction. We want to say, if you want to fund, you can fund, and here's the way to do this. We also want to underscore the whole idea of getting money to local organizations, which when you're working outside of a country, you don't understand the context, you don't know the context, or you know a context, within that particular community or that particular region. Very often we like to generalize. One of the things that we try to do in terms of talking about Africa is that we've recently changed our mission, and we specifically talk about African communities, because we want to underscore that the diversity and complexity and tapestry of what communities in Africa represent. We want to encourage funders not to overlook the organizations that are doing good work and that are doing good work in that community, because we all know that Ebola, as more than a health issue, is going to really depend upon those who are on the front line. And the people who are on the front line are not us. It's the members of those communities who live there and work there on a daily basis. So the current program that we're doing on responsive philanthropy, we're trying to really highlight the role of trusted local organizations who are focusing on issues such as the role of children. We know the impact that Ebola has had on children, on women, on families, on rural populations, on agriculture, small-scale farming. We're also trying to emphasize appropriate technology, because in rural communities we know that the radio is really one of the technologies that really reaches the most, and the radio in local languages. That's the other part of it that's very important to underscore. And that working through trusted organizations, not necessarily, when we say trusted organizations, that funders trust. We're talking about local organizations that communities trust, okay? And we feel that that's really important because having that trust means that you're talking about long-term engagement. You're talking about being able to make informed types of decisions. And so what we've been trying to do is to talk about the diversity. So I just wanted to very quickly talk about the different ends of the spectrum. So for example, the Foundation Center has been doing a great job of tracking funding for Ebola. And the last spreadsheet that I got from the Foundation Center Friday tracked about $350 million. And again, we're talking about one particular sector, which is private philanthropy that has a structured and formal way of giving. And within that list, I just want to pick out the range. So for example, that list has $10,000 to the Ellen Johnson Sirleaf Market Women's Fund to work in conjunction with the government, national government, and other partners. And that money was given by the African Women's Development Fund, which is an organization based in Ghana that works with women throughout the continent. The African Women's Development Fund also gave $5,000 to the new Liberian Women's Organization, the Skills Training Center, to conduct educational activities. So that's an example of funding at a level that is perhaps small, but that's important. On the other scale, the list has $5 million to the World Health Organization for emergency operations and research and development assessments by the Bill and Melinda Gates Foundation. So the multi-dimensional approach to addressing any issue has to take into account that you have a lot of different players in the pond, so to speak, and that one of the things that we want to underscore is that a lot of the response to the Ebola crisis, there's been a lot of discussion about not knowing how to get money to the ground. So one of the things we want to say is that, no, there are a lot of different pipes that are in place, that have been in place for a long period of time, that represent funders funding organizations who are trusted by the local community, so that there's not necessarily the need to try to do a whole bunch of due diligence and sort of figure out, and this is an instance where philanthropy has to really collaborate and work with your colleagues. And if you don't fund, but you have some money that you want to fund, talk to your other colleagues who are doing that. We also are trying to say that it's really important to not have this discussion without the presence and respect to the organizations and the countries and the people of those communities who are involved. Many of you know that there was a 60 Minutes report done in Monrovia on Ebola, in Liberia, in which you did not hear the voice of any Liberians, which I guess is excusable if it happened in New York, but it's kind of not excusable since it was happening in Monrovia, and you saw people walking in the background, okay? And I use that as just a metaphor to say that we all care about this issue because we're all here, and that what's really important is for us to know that we've got to do this in conjunction with local communities and local organizations who have local knowledge, who exist in those communities, who existed before, outside aid came on the scene and will exist after that. And that it's really important for philanthropy to be responsive, means you respond to the needs of the communities that you're trying to support and that you listen to that response. And although that takes time and it takes money and it takes having an understanding of the context, to one of the points that Jeffrey made about, are we here again? We say that, but I think that what's important is that philanthropy has to learn. We seem to not learn one simple lesson that we keep saying over and over and over and over again. And we keep saying that the impact of our work is seen through the transformation, strengthening, building the resilience of local communities. We keep saying that, but whenever we talk about our funding, we always feel that those organizations are ones that we say don't have the capacity, that can't absorb the amount of money that we want to push out. If that is indeed the issue, then we have to figure out a way to do that. And maybe that means that philanthropy needs to change the way in which we do work, as opposed to local organizations have to change the way in which they exist within the context of their communities. So what we've been trying to do is just to, one, keep the Ebola issue alive, to be very practical about ways in which philanthropic support can get to the communities of those 3 countries who need it, and to talk about the need for responsive and resilient philanthropy, in which philanthropy works in partnership. So I'll end with that.
Fantastic. It's a perfect spot, I think, to end on and to begin this discussion. And I think I'm going to kick it off, and I don't mean to throw anyone off here, but I think, Niamani, your last point on the importance of building resilience of local communities really struck me, and I think that that's a theme that I've heard both in the calls that we've had before this panel, but then also in the comments that everyone has made here. So I'm wondering if each of you would be willing to speak a little bit to how philanthropy can do that, and perhaps what you have seen in your work or the work of others wherein there are good examples of philanthropy supporting the resilience of local communities. Do you want to jump in first, or?
Sure. I think the resilience part means that, we talk about sustainability, and I think that the issue is not really about sustainability. I think it's about resilience, because sustainability seems to imply that we're going to, create a sense of capacity, or we're going to build something, and that it's going to be able to remain in existence for a long period of time without us having to come back and contribute any more resources to it. And that whatever the issue is that we've tried to address in this issue, the healthcare system, let's say, for example, that healthcare system is going to stay strong, and that we're going to build it up and it's going to stay built. But we know that resilience means that you have the ability to really respond to what comes along and to the things that we don't plan. And in the cases of both Sierra Leone and Liberia, you're talking about years and years and years of war and destruction. So I think that resilience means a couple of things. One, philanthropy, as I said, really has to learn the lesson and walk the walk of really respecting local organizations and the role that it plays. So I'm going to use the example of something like the African Women's Development Fund, just as an example. This is an African-based organization, gets support from around the world, both inside Africa and out, that works with women's organizations throughout the continent, that talks about supporting the role of women as change agents, as part of the political process, recognizes the important role that women play within communities, both in terms of the families, in terms of the community, on a much larger level. I think ADWF understands that you've got to make women strong in order to make communities strong. And so I think that that's the type of resilience on one level that we're talking about, building.
Jeffrey or Niamani?
Sure. In lieu of sort of transforming, I want to get there too, Niamani. In lieu of transforming, sort of the collective donor attitude and how they interact with grantees and specifically with local organizations, I think there's a part as a SFF hat, as a funder, that we can play in helping to translate and help our local organization grantees navigate this flawed landscape. So that's where some of this sort of non-monetary support comes in. Not if you can't beat them, join them, but rather this is an odd bunch of ducks, these funders, and so here's how you can speak their language and ideally have a little bit more, speaking from a position of power when it comes to designing mutually agreeable milestones and all of the impact metrics you're going to employ. I think you have to be proactive. The other piece I would say that we universally hear from all of our grantees whenever we get good feedback from them is, you can do all of the capacity building in the world, but please just introduce us to more money. So as a funder, just make those intros and be really proactive with it. We actually try to track that stuff, and we try to come up with a working definition of what leveraged money means to us. Money we can take credit for that we're not cutting a check for. I think that'll ultimately be the most powerful and respectful thing you could do for your leeway with their cash flow.
Well, resilience it's an interesting word. I'm not sure if that has been our objective in our work, is building resilience. I feel that the individuals certainly, perhaps not the communities as much, are already incredibly resilient people, and it's not something that we need to import. I think in many regards, seen through a healthcare lens, Paul Farmer really kind of expanded my, or validated, I guess, in some ways, some of the things that we were trying to work on through our model. I don't think as well that, I'll get to that, I don't think that philanthropy alone is the pipeline through which we'll reach not resilience, but prosperity. The reason I talk about Paul Farmer's perspective is that from a healthcare, through a healthcare window, his mantra is that, second-tier healthcare for poor people just doesn't get it. It's got to be first-class healthcare for everyone, no matter what your economic station may be. And likewise, the things that we've tried to implement in Sierra Leone through our model. And again, it's a hybrid of commercial and philanthropic investment, largely around natural resource development and mining. It's not so much so to build resilience, but to build prosperity, or to enable prosperity, to partner with communities toward prosperity. So the word resilience is not one. I think I don't know how resilient I would be in these environments, in these communities. I don't think I'd last a week if you left me out in the bush by myself. These are extraordinarily resilient, strong people. But as far as trying to build up, local prosperity, if I can use that word, I think that philanthropy obviously can play a significant role, so long as it's coupled with job creation, with economic growth. And when I look at this region, I can't help, as I was talking to Raj Punjabi yesterday, go back to this young boy, Emil Wamano, who was 2 years old or 1 year old, depending on what news source you hear, who died in this village, Miliandu, in the Zerakore region of Guinea, of southeastern Guinea. And the irony of this story, and I don't think that this has really been examined, is that in that same region is a range of hills called Simandu. And Simandu is one of the most exciting iron ore deposits in the world. It's about 150 or so miles from where this young boy died. They estimate that there are 2 billion tons of high-grade iron ore in this range of hills. Iron ore, I think, is scheduled to trade at about $85 a ton this year, down from 100. So you're talking, multiple tens of billions of dollars worth of value in these hills that's been monetized in the last 5 years, but none of that monetization has impacted the ground locally. We're talking about wealth creation relative to resilience, wealth creation for the international investor, but we're talking about resilience for local communities. And I think there needs to be a widening of the expectations of what we can achieve, if we expand or raise the bar on what we can deliver to folks. And so again, what we've tried to do is combine direct investment, commercial investment, with a level of philanthropy. So it's difficult. So yes, I mean, it's difficult when we're talking about giving here, and a donor-funded strategy here. But I think it needs as well to be coupled with a local awareness of the need for economic growth. And in these areas, these people are miners and farmers. And so if we can, in these rural areas, these most vulnerable areas, and so if we can couple that philanthropy with an awareness and appreciation for the engines of resilience and prosperity in these areas, if we can listen, because so often if you talk from a philanthropic standpoint to funders, they'll shy away from mining. The idea of mining is, as I mentioned, is totally off the range of possibilities. These people are miners, so they do. They're miners. They're farmers. So if we can couple our philanthropic approach with an approach toward a sensitivity to the economic engines, I think that would be an effective way to harness.
Being aware and understanding of the realities on the ground.
The realities on the ground, and not try to impose our own kind of cultural lens onto the local lens.
All of you have spoken about the importance of local organizations and partnering with local organizations, but certainly, as I would say all of us in the room are quite aware of, when these crises happen, you have these very large international NGOs that come onto the scene. And I'm curious to hear a bit more about what you've seen in terms of the interplay between these large NGOs and local communities, what's worked, what hasn't worked, where there have been areas of tension. Maybe we can start down the line with Andy, if you don't mind.
Sure. As a funder who doesn't do emergency funding by and large, we don't know how, we'll totally admit that. It was really confusing, but we felt that there was a moral imperative because we work in some of these countries already with sort of longer-term community development NGOs. It was really confusing for us as to who was sort of a legitimate actor and who was being opportunistic and maybe illegitimate, I guess, by contrast. Fortunately, with Last Mile, I think that they sort of bridge the gap between these two sort of very generalizing these two groups, which is local actors and international NGOs coming in. Mm-hmm. And further with the partnership with Partners in Health, it was this sort of not cynical but substantive partnership where you have international expertise and a local guide that also happens to be technically like sound health service provider, where you kind of had the best of both worlds. And we've pretty much kept our focus to that Last Mile partnership and a few things here and there. But we've tried to, otherwise we've been pretty darn gun shy. We've tried to not sort of have a scattershot approach to supporting a bunch of organizations, but rather find great organizations that we have pre-existing relationship with, fund them with unrestricted funding, and get out of the way. But I don't know if there's a recipe for navigating the two camps of sort of local orgs and INGOs.
Have you heard from other local partners on the ground about their experience in working with large NGOs and how that dynamic has been balanced?
I don't think it's been balanced. I think local folks get pushed around, and it's not just like the might and the size of INGOs, it's also their experience.
Right, absolutely.
They've come in from previous conflict situations, and they can just the fashion of memorandums of understanding and sort of how you who's passing through funding to who. All of these technical pieces are completely foreign to a lot of the organizations we work with, either small, local, or just unfamiliar with emergency response. It's tricky. Again, I think that's where ideally, I think maybe you guys have done a pretty good job with helping to craft the Open Society. Has been a pretty benevolent funder, from what I understand, about sort of making sure that the important players had sort of equal voice at a table, and that there was a just or judicious way to sort of allocate resources. That was it was an umbrella, apportionment of funding.
Our experience has been, relatively narrow, to the organizations within the coalition. So, it's been relatively smooth, kind of ignored the larger surface, and just focused on, those things that we could, attack effectively. Again, in terms of, cooperation, if that's, what you're getting at, I think, I can't speak to experience outside of what we've been doing, but I will speak to something that Andy brought up earlier about Last Mile's work, for example, in terms of building up local community capacity, local community-based capacity, is that one of the reasons that we built this coalition in such a way that does work together in harmony with international NGOs like Partners in Health, like Last Mile is more local, but has an international reach, is toward this larger vision, which was really kind of inspired by what I saw in Rwanda with Partners in Health, whereby you have, you have these satellite kind of local community-based healthcare workers, but in order to create, real defenses at that last mile, they have to be tied to an anchor primary care unit that can't be a temporary unit, but that has to be a real facility, real infrastructure. They can only do so much. So what we're trying to do in terms of coordination is coordinate the skills and the experiences of the last mile of Partners in Health, and kind of bind it together with the experiences, for example, of Mass Design Group, with a group of Harvard-educated architects who build hospitals and facilities in developing countries, and coalesce around those complementary talents. So within our coalition, seems pretty harmonious, at least theoretically, but I can't speak to the outside our framework. So.
When this question is raised, I'm always reminded of something that most of us have probably heard many times, but it's the African proverb that says that when the elephants fight, it's the grass that suffers, right? I think that one of the difficulties of working in this area is that we all have our notion of, we're all sort of social engineers in a way. We all, recognize an issue and we're trying to address it. And I'm always reminded in philanthropy of the discussion between, scientific philanthropy, and Andy and I were talking earlier about, impacts and sort of the business model toward development and so on and so forth. And kind of where's the heart of philanthropy in terms of people and charity and doing, and how do you know that you're doing the right thing? I think that the international NGOs, we all know, are probably, as Andy said, more savvy at the business of philanthropy, But being more savvy at something doesn't necessarily mean that it's making an impact. I hear a lot from not only funders, but organizations based in these countries, media coverage, not necessarily by the US media outlet, but many of you probably know allafrica.com, that probably has, more coverage of what's going on, and other African-based media outlets. But I think that there are some issues that are not new, that are long-term, that again go back to this issue of whose agenda, are we furthering, and how much weight do we put to the vision that the people in those communities have for what it is that they're trying to do. And, I respectfully want to push back a little bit against my colleague here about the whole term of resilience. Because I think that resilience is important for all communities, only because we have no idea what's in store for us. So I think in terms of international NGOs, there's some reports that you're here that there's a lot of tension between international NGOs and locals. A couple of individuals have talked to me and said, well, no, I was at a meeting of a group of international and local NGOs, and there's, kind of collaboration. So I think that one of the dangers of all of this is that we want to kind of know in broad strokes what's happening, and I think it's very localized. Mm-hmm. But I do think that, as Andy said, that you're not going to change the practice, and you talked about introducing folks to more money. But I would like to also offer that if you don't stop repeating the same mistake over and over again in terms of the agency of local organizations, then in his remarks, Jeffrey talked about the amount of money that's been put into aid. And so I think international NGOs and local NGOs need to work together. And I think that what I've heard in some cases is that the selection, bringing it back to the issue of Ebola, of facilities and resources that international NGOs are identifying may or may not be, in alignment with what local communities are doing. So, I mean, I think that it's not so much about creating international NGOs as the bad guys and local NGOs as the good guys. It's not really as simple as that, but it's about how can we, work together to really have an impact on this, because it was HIV, it was malaria, it was, and just the last comment I want to make is that one of the things I think that's really important to remember is that, and Andy alluded to this, local organizations in those communities, the local group that's teaching young women how to sew, that's dealing with healthcare, that's dealing with housing, that's dealing with social entrepreneurship. All of those organizations have had to cease and desist, all of that for the most part, and really focus their efforts on what's in front of them. And the collateral damage of all of that means that Ebola has created this wall against, and around people. So I think that the international NGOs and local NGOs need to also address the fact that after this is over, we're talking about a fundamental change, to these communities because of the isolation that this has created.
Speaking of it, do you want to jump in with a question?
No, I did want to
please.
one small one in that, do I have to, do I have this thing? Yvonne Moore from the Daphne Foundation. So I just wanted to offer really quickly that actually, a larger NGO, UNICEF, actually been working with the Ministry of Health in Liberia to come up with a universal training program around outreach, because we had seen some very dangerous things around outreach, people meaning very, meaning well, but just kind of not carrying out the work the way in a safe way. And so they've actually connected with communities in West Point. I know for a fact that with our grantee West Point women, we learned about the training from UNICEF, and we were like, is it open to our grantees? Can our grantees come to the training? And so they were able to connect with UNICEF in Liberia and actually participate in that training. And so, the message is consistent across communities, at least within West Point. It hasn't been without its challenges, but it's been really great.
I'm going to ask one final question of the panelists, and then I think we're actually going to have the opportunity to watch one of Jacque's PSAs. But before we do that, since we are here thinking about philanthropy and philanthropy's response, I'm going to have a two-part question. The first is whether you have seen an interest from organized philanthropy in addressing longer-term issues. And the second is if there are any examples that you've seen of innovative responsive philanthropy that really gives you hope that these, not only will the longer-term issues be addressed, but that we won't be having this conversation about Ebola or another epidemic in the near future.
Wait, so the first part of the
so long-term, yes, long-term interest, and as well as just interesting and innovative responses that give you hope.
Yeah, I'm going to beat a dead horse.
No,
this potential decade-long sort of overhaul of the Liberian health system in conjunction with the Clinton Health Access Initiative, Last Mile Health, and the Ministry of Health, of course. I hope it's going to be underwritten by the World Bank, which is not a sort of usual suspect when it comes to underwriting these types of long-term public goods. So I think that there's a lot of really smart and well-spoken folks like Paul Farmer who, in this context, are beating the drum of sort of this is a crisis born of a broken healthcare system as opposed to a specific disease. And if you want to mitigate future outbreaks of X, of Ebola or what have you, there needs to be legitimate, investment in infrastructure and people in supply chains. And like I said, I'm hopeful. I think we're, at least in the context of Liberia, and I hope elsewhere in Guinea and Sierra Leone, that there's big money and big, smart people, local actors and otherwise, who are legitimately invested in this long-term change.
Can I beat that horse as well? Because, that's, and I think that's Partners in Health intent in Sierra Leone as well. It may not yet be as formalized, and I think that's probably a function of still the immediate needs in Sierra Leone, having not been as stressed as they have been in Liberia. And I think that's an interesting dynamic too, a function probably, not to digress, of the kind of adherence to these colonial stovepipes, whereby the United States deployed, its military and funds and, full attention on Liberia and left Sierra Leone to the British and Guinea to the French, and neither of those colonial partners, shall we say, has been as robust in its engagement as Liberia, as the U.S. and Liberia. So, but I do think that discussion will come in Sierra Leone relative to a 10-year commitment. I know personally from Paul that that's his intent there as well, and that has been really, as I said before, continuing to beat that horse. The inspiration for my putting this coalition together was seeing the work that Clinton Foundation and Partners in Health, along with Jeff Gordon, the NASCAR driver, in fact, through his foundation, was and as well probably the most significant partner in all of this, the Ministry of Health in Rwanda, whereby they built this modern facility. I think it was at the cost about $4.4 million in 2010, $4.4 million, but it's built again and designed by Mass Design Group, and it's built in the right way, with an attention to local detail. Wasn't some modular unit that was shipped over from Florida, be fashioned there, but they used local materials, local stone, the skills transfer between the group and local labor and local designers even. But it was critical to this overall strategy of satellite and anchor that you do have a modern facility in place that is really the backbone of the strengthening of this last mile rural healthcare delivery system. And so that's been the inspiration. That's the only model I've seen anywhere in the world, and I haven't been to all of them, but to all obviously. But it's an extraordinary, powerful piece. And I think the last mile of that mile is this. It may not be a discussion necessarily relative to our work here. How do you maintain it going forward? Because I remember having a conversation with Ira Magaziner in Rwanda. Said, "Is this sustainable?" He said, "No." but I think within the context of Sierra Leone, Guinea, Liberia, and the rural northwestern, northeastern, southeastern for Guinea, northwestern for Liberia, northeastern for Guinea, it is sustainable. And one of the ways in which philanthropy, I think, can be most impactful in this response is to engage the private sector and demand of the private sector active in that region to be equally committed to the immediate response and also the long-term response. I was at this UN ECOSAS event, and it was a great gathering that Paul Farmer led, maybe 3-4 weeks ago, in which he led the dialogue, and one of the representatives there was ArcelorMittal, the mining company that's operating in northeastern Liberia. He, in fact, I think is the chairman of this private sector, Ebola private sector mobilization group, which is a great strategy for private sector involvement and partnership with the philanthropic group. And one of the questions that I've had about how we can maintain a system like this, and it's not through philanthropy that it's going to be maintained, it's got to be maintained through local tax revenues or through local royalty, a health royalty on that, on the healthcare royalty on that 2 billion tons of iron ore, for example, in southeastern Guinea. And that geologic trend extends over into Liberia as well, a health royalty attached to the 3 or 5% royalty that's paid off of production that goes directly to the sustaining of these, the healthcare infrastructure and the systems that are delivering into those remote areas. Likewise in Sierra Leone as well. There's significant resources in that northeastern area as well that, if developed in partnership with philanthropy, could have extraordinary long-term transformational impact in that region. So I'll whip the dead horse and add a private sector spur into it as well.
Private sector as well. Local philanthropy, interested within that. Niamani, any closing thoughts related to that?
I hate to be the voice of skepticism. But again, looking at philanthropy from a big picture perspective, I mean, development on a national level is really, there's not enough philanthropy to really make a dent in terms of that, number one. And number two, if we're all honest, we all know that philanthropy has a very short attention span. And that when you're talking about impact, you're talking about impact, 3 years, 5 years, maybe, but that there are very few instances, and it's not only philanthropy. I mean, I can use an example of, I used to work on a project for USAID in education, and in the missions in Africa, which is the area that I worked in, mission directors were there for a long period of time, and so the amount of money that was being put into education was for long-term training. And then there was a switch to impact, and so then there was a switch to short-term training because mission directors needed to be able to demonstrate in the 3-year time period of their tenure that they had made an impact on, training for that country. So I think that, we all have to be kind of real about the context in which we operate. But that being said, again, I think that the more we strengthen the partnership in a real way, and the more we talk about how we're supporting, national development plans and how we're supporting the vision of the future that African communities have for themselves, then I'm more hopeful that we're going to talk about long term. But I still think that given the way in which just life happens, that, we talked about HIV/AIDS and the impact of that on the African continent. And, I have friends and colleagues who are concerned about the lack of funding for HIV/AIDS in terms of, trying to deal with that long-term issue. So, we're not going to be able to solve any of it. But I do think that philanthropy is probably most effective with short-term, very specific things that it's trying to do in which it's going to put its funding into. But philanthropy is never, in terms of private funding, has never, and probably is never going to, unless it changes the way it operates, be able to invest in any long-term impact because it's not going to stay on course for 10 years or a generation, which is the amount of time that it needs to really, demonstrate that. So, you all can shoot me after.
Can I gently push back against that? Because I think if you're talking about building infrastructure, philanthropy toward building facilities, clinics, hospitals, and if it has the right support network around it and system around it, and again, if there's a strategy in place for long-term maintenance, I think philanthropy can have a transformative impact in this specific arena. But perhaps I'm just optimistic, and sky's blue and overly.
And not to right, and I guess that just for a clarification, what I'm saying is that you have a very important point in that when you talk about long-term maintenance. And we see this, and I'll give an example in terms of building schools. We have this tendency to go into an area, identify a school, even though we don't really investigate, is it really about the school, but someone tells you, oh, there's no school in that area, so we go in and we build a school, okay? We built a school, but we haven't really sort of talked about, as we would do in this country, we talk about urban planning and, population and transportation flow and all the things that go into that. And then we find that, oh, we have this beautiful school, but the problem is that, we don't have money for teachers or so on and so forth. And then we criticize the community in which we built the school. And we say, oh, we built this school and, it's on you. Why can't you just, maintain it and do whatever? So I guess what I'm trying to say, Jeffrey, in a very positive kind of way, is that it's really important for us to know what we can do.
Sure.
And know what we can't do. And that if we want to be strategic, and we want to be responsive, which don't necessarily have to be mutually exclusive, but I think very often is, that we have to really understand, the reality of what it is, because I go back to my original, saying, is that it's the communities I mean, you talked yourself about the, signs that are left, right?
Sure.
So we have to be really self-critical
Oh,
about,
absolutely.
what it is, and it's all aspirational. It's like, as I was saying to Andy, it's like democracy. I think that all of this is aspirational. It's aspirational. We're trying to get it right. We don't always get it right, but we're going to keep trying to get it right, and we're going to keep trying to have these conversations and be self-critical, make sure that we get it right, because it's the African communities that we're acting upon and putting all this, our resources in, that are really the ones who are going to have to rebound from, this attention.
Let me just say one. But what makes me extraordinarily optimistic about this opportunity now in Sierra Leone, Liberia, Guinea, is that you have visionaries like Paul Farmer, who hadn't previously been in this area. You have partnerships with local groups like Last Mile Health, like Well Body Alliance, like smaller, lesser-known groups. When I first went to Sierra Leone in 2001 during the war, there were 17,000 UN troops and personnel in country. Again, to contain the violence of that war, myriad NGOs. Unfortunately, there was no transformation in that country as a result. There's a lot of economic growth in the last 3 or 4 years, but Sierra Leone was scheduled about 15.4, I think, percent economic growth this year. So there's a lot of progress, but that largely came from Chinese-related investment in the natural resource space, in mining. But there was no real transformation that took place as a result of that engagement by the international community to end the war. But this opportunity has to be transformative. It has to be used in a way that sees real transformative progress take place, specifically in the healthcare delivery space, but hopefully it bleeds over, not bleeds over, it's a poor choice of word, but hopefully affects other sectors as well. But I'm terribly optimistic because of the folks that I see surrounding this, and also the mistakes that we personally have made and we collective have made in the last years in this region. I'm optimistic that this will be a real leapfrog opportunity and a leapfrog moment that's seized upon toward transformation in this area.
Good. Well, with that note of optimism, I think that's a perfect point for us to turn our attention to the PSA.
Oh.
Thank you. Do you want to say anything about what we're about to see?
Yeah, you might want to pause it. I think I've said too much already, but these are, I just. Yeah, I'll let it speak for itself.
CDC declaring a level 1 activation
The world is facing the largest Ebola outbreak in history.
But the countries hit hardest are Guinea, Liberia, and Sierra Leone.
Look at this worse than. In some parts of West Africa, only 2 out of every 10 that's lived with Ebola has survived. 20%. 20%.
Why?
Why? People infected by the Ebola virus in Guinea, Liberia, and Sierra Leone
Don't have access to the same medical treatment as Americans.
They need IV fluids to maintain blood pressure, electrolytes to replenish losses, and also food, just like any other critically ill patient would, just like you.
They need fully equipped modern hospitals.
If they had those, then we have competition. And they need many more well-trained West African medical professionals.
A lot of them didn't make it.
Yeah, they didn't have nothing to begin with. In Liberia, they had 50 doctors for 4.4 million.
And high-quality, supportive care, the great majority of people in West Africa will survive Ebola.
Ebola is not a death sentence.
No, you got it. A lot of doctors.
And then you can go to 11 Girls, such as some data as well. That's the That's the second chapter of.
All right, thank you.
I mean, that, you know, this was the second of the, you know, the PSAs that we put together. Just released this the last week of December, just to increase the awareness of and deflect back toward West Africa, which has been our message from the start. I hope that the messaging reflects the engagement, in that the first person that speaks in this is this young girl, Asfata Touré, footage that we got from Paul Farmer's Partners in Health. That, and in spite of there's a media fire lit around this thing, around Jennifer's participation, and I'm extraordinarily generous, extraordinarily grateful for her generosity and everyone else. But very few of the news reporting about even this piece mentioned that young girl had spoken. That she was the first to speak. In fact, the Telegraph embedded a version of the video on its website, and I understand why they cut out the first initial American news media footage, but they started it with me. They cut that young girl out, which seems to me, it's just unfathomable to me how you could not understand that that's the story. So I say all that to say that I hope that what the message there is reflective not only of the narrative that we send, but the type of engagement that we have undergone, that we intend further. And that it's, as Niamani said, with an attention to the quality of our listening and hearing these local folks. And a celebration not only of their vulnerability, or highlighting not of their vulnerability, but a celebration of their strength as well. Because again, as Niamani said, it is they who will be the problem solvers in the short term and the long term. So thanks for the opportunity to show that.
Absolutely. And so with that, let's open up for some questions. I think, did you have the microphone?
Hello, everyone. My name is Salome Lemma. I'm with an organization called Africans in the Diaspora, which is organizing the diaspora to engage in strategic philanthropy. And in response to Ebola, we co-founded an initiative called Africa Response, which brings together multiple African diaspora organizations to raise money to support local grassroots organizations and to tell their stories so that they are part of the narrative that's told about Ebola. And the question that I have for you, I remember kind of working on the tsunami grants at the foundation at the tail end of that. And we were having a lot of conversations about how important it is to support grassroots organizations and how we want to do better next time. And then Haiti came, and we talked about how important it is to support grassroots organizations and how we need to do better next time. And then Ebola came. And according to the Foundation Center, I think 78% of the Ebola funding has gone to about 5 or 6 organizations. And then the remaining has gone to other international organizations. And from that, very little is to reaching local organizations. And even when we talk about local organizations, we don't really have a common definition. I've heard so many people describe, for example, Last Mile Health and Partners in Health as local organizations. Both are fantastic groups doing really important work. But they're different from indigenous organizations, like the women's associations that are organizing market women, that like the youth organizations that were going door to door to educate their communities. They too deserve support, and they too need to be part of this narrative. But when it comes to an emergency, we always kind of go with what we know, what's comfortable, what's easier, what's safe. So how do we, as members of this philanthropic community, think about innovation, experimentation, risk in the context of emergency? Because that's when it's most important, so that we're going to the sources that need it the most. And within that, the second question that I have for you is, we know that the impact of Ebola has been gendered, right? We know that kind of the disproportionate impact that it's had on women. And I would love for you all to talk a bit more about in terms of what your partners are doing around that, if they're working at kind of the nexus of intersectionality around gender, health, education, and economics, and how we can learn from that and what we can do better.
assigned the question to.
What was the first question?
The first question was around getting money to local organizations.
So we were having this conversation about authenticity. And I wonder if you go to someone in Grand Jetty County in like remote southeast Liberia, they would probably think someone from Monrovia was as foreign, as alien as any one of us. So I think that's really tricky. In terms of accessing local organizations, as I mentioned before, it's like kind of think of a 1 degree of separation rule. We've tried to focus on funding people that we already knew, had a direct relationship with, and could vouch for their good work during times of stability, or just 1 degree of separation. So another funder or one of these trusted organizations we're already working with to make recommendations, which doesn't help you get to really true community-based organizations. I think there's some decent proxy organizations. I'd be curious offline to know what you think of it. But we met an organization called Women's Campaign International. And apparently they have tens of thousands of women's groups tens of thousands of women within women's groups in Liberia that they're mobilizing for basic door-to-door case identification, contact tracing, and the like. So, there's a proxy. There's a big 501c3, an INGO, but they've accessed local distribution networks of knowledge, right, for distributing knowledge and also doing some response work. So there's no easy silver bullet here. I guess you just try to find that trusted entity or 1 degree of separation from that. In terms of the gender work, yeah, that's tricky, no doubt. On last mile side, most of the community health workers that they're training, I think it's probably like a 60-40 split right now, men versus women. And that's usually tied to sort of educational backgrounds, some basic literacy, which unfortunately, women have much worse rates of literacy in rural and remote Liberia. But certainly I do think that the more female community health workers they can train, the more appropriate the response will be in terms of doing community sensitization, because there is such a huge imbalance, like 20-80 in terms of the case rate, men to women.
Niamani, any thoughts on the local?
Well, yeah, I mean, I think that, one, your point about the definition of local organization is very true. And I guess, as Andy said, there's a rabbit hole that we can go down in terms of the whole question of, what's authentic. And again, I think understanding that there are communities and there are voices, it means that perhaps it pushes against our want to, kind of have the spokesperson for that. I think that the issue, and again, if we want to be candid about local organizations, is very much tied to money. And that there's in one of the calls that we did, we talked about the role and the important role of trusted local organizations. And one of the conversations that immediately came out was we have to be careful about, flooding local organizations with a whole lot of money because, it'll destroy them and they can't do it and so on and so forth. And I said, well, I think that it's really important for us in general to talk about the importance of balance regardless. But I think it's interesting that tends to be a knee-jerk response when we talk about funding local organizations, which kind of ties back to one of the points that Jeffrey was making about, the quality of care. And I think it also speaks to our somehow we feel that local organizations, and this is not only true in the international context. A colleague of mine sent me an article once talking about, how you starve nonprofits because, you don't want to give them too much money, because if they have too much money, then, either they won't be judicious with it, or we don't want them to have big endowments or big, operating funds, because that's the bailiwick of foundations, of course. So I think that local organizations, I think that we have to really be honest about the fact that, local organizations, we feel we would never think about giving $5 million to an international, to a local intermediary without a whole lot of due diligence. Not that it hasn't been done, but we wouldn't blink twice in giving, $5 million to an international NGO, because we are making some assumptions, and I'm speaking very broadly now, about capacity. And I think that it's true not only, Salome, domestically, I mean internationally, but domestically as well, is that we tend to starve organizations. We don't give them enough. We give them just enough in terms of that. And I do believe that one of the game changers that exists now that didn't exist, maybe 5 or 6 years ago, is that you've got the African Grantmakers Network, which is a network of African-based grantmakers and philanthropy. You've got the East Africa Association of Grantmakers. Again, just talking about formalized philanthropy, not talking about other sources of philanthropy. You've got the South Africa Grantmakers Leadership Forum. You've got the Danjuma Foundation. You've got. So we have, as a field, partners now that didn't exist before. And so I think that one way to address that is to talk about how you can work closer with that, to make sure that you get funds, to the ground in a way that is fiscally responsible and comfortable in terms of that. Your second point about gender, I think that unfortunately, I remember reading and being very alarmed. The Population Council is doing some great programs around Ebola and the impact on women and children, and raised the issue, which I was not aware of, that the recommendation is for condom use up to 2 months after infection, once you have gotten cured, because of the ability to reinfect. I've heard from people on the ground that's not being talked about. So that you already have some instances, from what I understand, where this has actually happened. So I think that, again, women and gender, traditionally, we have always had problems, even though we pay a lot of lip service to women. We have a lot of problems with supporting women, and that in philanthropy, as you all well know, there are sort of the focuses, the sort of trends in philanthropy. So, HIV/AIDS was a trend, so we made sure that every organization had an HIV/AIDS component to its work and that we wanted to fund it. And then we don't talk about that, and now we talk about diversity, and then we talked about gender and whatnot. So I think it's about really due diligence and being intentional about that.
Yesterday with one of the organizations in Nigeria. They had a woman and she's been home because of the sexual violence going on in the bottom, right? And she is in Mexico, right? It's not legal for her. But she said you can't believe the numbers of women every day because we just woke up and nobody talks about it. And we're assuming talking about it and we're just listening. I just want to comment on Alexander that when we back into the issue sexual violence.
It is women's economic empowerment as well, a means to address it outside the clinical approach. What we've been doing is working with women farmers directly, but directly, not necessarily, one step away as you described. One of the things you mentioned in terms of identifying local groups, obviously there are barriers to capital in place and different levels of qualification to apply for funding. But there are also I think we use different lenses to identify what is a local group. Is it a local NGO that looks like what we think a local NGO might, might look like and behave like, or is it a local chiefdom in Sierra Leone, a local community, which is a highly organized cosmology, with compartmentalized responsibilities, but you wouldn't necessarily view it as potentially a funding target. Because it's not a local NGO, it's a local chiefdom. But so those are kind of structural challenges, that need to be addressed through due diligence and through kind of a transformation of the process, as was mentioned, but also, I suppose, through working through proxy groups that have these direct relationships with local chiefdoms. And there's a tension between local chiefdom governance, local chiefdom structures, and what are viewed as Western structures, more, kind of which are kind of descendants of a colonial past, and whereby there's an attempt to kind of, sideline the strengths and the and the authority of the local communities, local chiefdom structures, traditional structures, relative to the more Western. So, I mean, it's a huge challenge that that one needs to be sensitive to in in engaging, but not all are necessary.
By the way, so sounds like cool work with African response in the diaspora, mobilizing those guys. So I'd be interested to hear more.
One observation and one question. So just on the, we've done a lot of work on documenting the response here to Sandy, and I'm hearing people say we need to fund locally based organizations when disaster comes, and not just the American Red Cross. And that conversation's been going on for years, and still in this last go round, most of the donations still went to the big American Red Cross, and so it's a perennial problem everywhere forever. So good luck. Sorry. My question is, so if an advisor was working with a funder who wanted to give money that doesn't have an Africa office, but that wants to make, a certain size grant for a one-time thing or a short time period, it isn't going to be committing to a whole African office themselves or anything like that. How would you suggest to them that funder approach or find the right grantee or the right process for finding the right grantee? Are there organizations that are tracking in these 3 countries, NGOs that are doing good work and that somebody could turn to?
I'll take a stab at that one. That's actually very much what we're trying to help facilitate. So just last week, I got a call from a staff member of a donor-advised fund who has a donor who would like to make a grant in support of the Ebola crisis, and who is particularly interested in women and particularly interested in having an impact. So I said, okay, do you have any preference for country? No preference for country. Any preference in terms of any other, even though funders say they don't have any preferences, usually what happens is that when you give them some choices, they do. So what we do is that we try very much to not be a gatekeeper. So we put them in contact with our members and other funders, particularly grant-making public charities who have relationships with organizations and know organizations really well because they're also involved in that work, and try to give them kind of what I call a menu of starting points. And then you can talk to, I'll use Global Fund for Children as just an example. Global Fund for Children has 20 organizations in Liberia and Sierra Leone that they've worked with over the last 5 or 6 years that they feel are trusted, they have evidence that are trusted, that are doing good work. And so we say, okay, why don't you have a conversation? And we help to facilitate that with the program officer who's doing that. I'm just using them as an example. So what we try to do is say, there's no need for you to go through all of this to try to vet organizations, but there are a lot of organizations as well as funders, because funders kind of like, to feel that the organization have been vetted. Grant-making public charities and other funders who are funding in these countries, who know about organizations, who can really speak directly to their experience and their impact. And so we try to say, here are some options if you'd like to fund. Because we feel that no one should say, I'd like to help, but I don't know how. Because we say, you don't know how, we'll be really happy to work with you to figure out a way to get that money out of your hands into, the hands of folks who have trusted relationships, without acting as a gatekeeper and without making any assessment about you should fund this or that, because we feel that you need both the large funding as well as the small funding. So if the donor wants to do $5 million, we can give some recommendations in terms of that. If they only have, 30,000 and it's a one-off thing, then we can say, here are some recommendations in terms of organizations you can talk to, and make your own decision about how to do that.
Perfect. Do we have another question?
Well, just to piggyback on what Niamani just said, and I was actually going to make the comment that you made, Michael, about the perennial issue that we deal with as funders in terms of funding, disasters. And I think that what you just brought up, Niamani, is really critical. And Andy, you mentioned leveraging dollars, but what happens every time there's a disaster, environmental, health, is there are a whole slew of different funders, whether it's private foundations, individuals, corporate foundations, but also corporations. And what happens is, and the media plays a huge part in this, of course, is people want to act quickly, they want to be effective, and they want to have assurances that their dollars are spent properly, and yet we keep coming against this. So I do think it's something that as a community, as a philanthropic community, we need to address in one way or another, because that's why, and nothing against the larger international NGOs, but that's the easiest, simplest reason as to why the dollars go so quickly and immediately to those entities.
I'm thinking as well, relative to Haiti, were there not 10,000 NGOs operating in Haiti prior to the earthquake?
No, it's a significant number of local organizations.
There were 10,000 NGOs, so there was one for every 1,000 people. And yet, the earthquake hit, and there was no resilience. So I mean, that's a huge, critically important question. And I think from our standpoint, in terms of the coalition that we built, is why we tried to be very selective and very strategic about who we included within the circle, because they had a prior relationship, except for Partners in Health, which is our exceptional partner, but had a prior relationship to the region, had been proven effective, and intended, a long-term relationship. So I can say in the case of my group, Thai Peace Foundation, we're essentially representatives of the chiefdom the chiefdoms we work within. Two chiefdoms, about 50,000 people in the West. We've got a couple staffers over in Sierra Leone, but basically, we direct our funding directly to whether they be youth groups now in one chiefdom for kind of a border patrol exercise, or women's groups through women vegetable farmers and processors of agricultural products like cacao and things like that, or the deployment of these infection control materials, which went directly to chiefdom authorities, paramount chiefs, section chiefs, and the like. I mean, we're really just kind of a gateway for these communities.
Local connection. I think we've got time for one more question. The microphone got passed on there.
So I was going to sort of mirror what both of you said about sort of the larger international NGOs and sort of the desire to make sure that your money is getting out there quickly, and perhaps the peace of mind that it's possibly being spent in the way that you want. But I think we can't discount the role that these groups play in employing local actors. So, have large national, local workforces in addition to their international workforces. So I think it's a little disingenuous to say that they're not, and again, the definition of local can be very broad, but that they're not, in fact, local actors. But my sort of bigger question was, there was a lot of talk about sort of the narrative and about how the Ebola response has been handled. And I was curious sort of how we in the philanthropic community can make sense of that when there are many competing narratives. So sort of what comes to mind, bless you, most specifically, is that some groups have been very critical of the response of the WHO and the CDC. There wasn't enough. It wasn't quick enough, there weren't enough resources. And then individual NGOs have been critical of each other. Your treatment methods are ineffective, and so your survival rates are low, and this is the treatment method that we should be pursuing. And sort of there's not been really universal agreement, most likely because there's not really a universally agreed upon vaccine or treatment method. And so kind of getting at that second tier healthcare approach for people living in these countries. And so, from a philanthropic perspective, like, how do we make sense of that when there are so many competing narratives?
Well, one of the things that I would like to say is that I think although Guinea, Liberia, and Sierra Leone are 3 countries in West Africa, they're 3 different countries. So I think that, again, and we all do that. We all want kind of, I want to help, so tell me what to do and tell me what the right thing is to do, and, so on and so forth. I think the unfortunately, there is no narrative. I mean, if you look at the media, the narrative has nothing to do with those 3 countries. The narrative has to do with the intervention from the international community in terms of what's going on. But I do feel that there are many narratives, and that what funders need to figure out is not only a funder institutionally, but even I say this to individuals who call us up very often and say, you know, we want to help, can you give us some direction, is that there are a whole lot of options for ways in which you can make a difference. And there are a whole lot of options that can be tailored to what your interest is, what your level of funding is, what your comfort level is, and also that meets the needs of what's going on the ground and meets the needs at international, national, you know, global levels. And so you can find a fit, you know. And so for us, we try to underscore that because personally, I think that the finger pointing is counterproductive. And, you know, it may have been true that, you know, the response was slow. You know, a lot of things may have been true, but here we are. So the focus that we've been trying to say is that, so here we are. And so you have to do the best that you can do with what you've got where you are. And that we certainly have access to a lot of information, you know, and that there's no need to say, I don't know, you know, I'm confused, I don't know what to do. A foundation staff person said to me, I'm really confused, I don't know what to do. And I said to them, I'm not going to accept that from you because you work at a foundation, there's a lot of resources, you have a lot of staff, you have access to a lot of information, so you can sort this out. You know, you can sort this out and you can make an identity, you know, you can decide what to do, and, you know, don't be afraid to make a mistake. You know, I think it's someone else's organization. Was it yours who had the PSA?
We've made some mistakes.
No, the one that said, no, someone had a PSA that said, this is what inaction looks like.
No.
It wasn't you.
No,
okay.
No.
You know, but that, you know, that the important thing is to do nothing. I mean, the important thing is not, you know, it's to do nothing. It's to do something. I don't know if my colleagues have this one.
But I think specific to this, there is a debate, a clinical debate, and neither of us is really qualified to, shine additional light on it. But I think it was fairly well highlighted in the New York Times article about, you know, this division among, you know, and it's really around IV therapy, really that simple. If you read certain descriptions of certain ETUs, Ebola treatment units, I think there's probably less T in ETU than one might expect. Just taking, you know, some of the, you know, you pick and choose through the, you know, the media what sounds right and doesn't, and I kind of bounce it off Paul Farmer is the way I kind of, comb through this stuff. But for example, the NBC cameraman who was afflicted and treated initially in an Ebola treatment unit in Liberia received for his treatment 3 buckets, a gym mat, space on the floor, and time to die. He crossed over into the confirmed cases, past the orange barricade into the confirmed case space, and that's what he was given. He survived. He was, you know, evacuated out to Nebraska or wherever. But I think there is a significant difference in treatment styles and protocols of certain groups relative to others. And again, I played Dr. Narcisse on Boardwalk Empire. That doesn't qualify me as an MD. But I can say the coalition that, you know, we decided to build was based on those that were talking about a higher level of care as being necessary, not only for, you know, the immediate intervention in terms of bringing down case fatality rates, but in terms of long-term, you know, as a step toward long-term strengthening as well.
And if you want to add anything to that?
Sure. Just from the last mile perspective, I mean, there's plenty of built-in technical expertise around health. Just the sort of overarching ethos, which is shared by PIH, is health as social justice. You know, that where the market stops, like there's place for philanthropy to subsidize health outcomes, no matter how dire the case or how remote the case. And a couple of plugs for for people searching for stuff, and this is obviously fund last mile health first. But geographically, you know, we've not mentioned Guinea, and being a francophone country sucks. Sorry, from this lens of receiving of Western aid. And I personally don't know what the heck's going on there because it's out of the news. I would be really curious with the Andy Foundation, if that existed, to look there. Secondly, is going to be in mental health service provision in the next forever, where you're going to have a significant portion of the population that's going to be really, really traumatized, and it's going to undercut your basic sort of meat and potatoes, health and livelihood and agri and education interventions because people have lingering trauma. And I don't know who those actors are, but there's got to be someone out there who's ready and has the right sort of stuff, and ideally folks who've already been providing it in country for some time.
Excellent, great. Thank you, and thank you to all of our panelists and to you for your questions. I know that there were many more of them as we move to the question and answer, so I think we'll stick around here as long as we can, and I know that there'll be contact information and website information on the Philanthropy New York website. So thank you again, and thank you for just your presence here and shows your interest in this area, and together, ideally, we can continue to keep this on Philanthropy's radar, so thank you.
Don't you just love famous people who know what they're talking about?
I'll find one for you and see how much you love it.